Hello everybody. For those of you I haven't met, my name's John Glasby. I'm Professor of Health and Social Care at the University of Birmingham. I'm currently head of the School of Social Policy, and for a number of years I was Director of our Health Services Management Centre. Most of my research has been around joint working between health and social care and the way in which we can bring together services to work with particularly older people, but in fact all groups that have complex needs or have multiple needs. I've been working on a national evaluation of community hospitals, working very carefully with a range of partners, but in particular the Community Hospitals Association. And I've been invited by Helen Tucker to provide some input at the conference around joint working and integrated care. Unfortunately, due to a diary error at my end, I'm not able to be with you in person. And I'd asked Helen if it would be helpful if I recorded a short video clip about the kinds of things that I would have said, so that she could send that out to delegates as an extra resource above and beyond the conference programme. So I hope this is a helpful contribution to the debates that you're having. I guess if it isn't helpful, you can either press stop or you can delete it in a way that you can't do with speakers when they're on the platform in front of you. What I wanted to do with the time, if it was okay, was say a few words about the current policy context and about the importance but also the complexity of joint working, and then share a few insights around the evidence base and around the implications of that for community hospitals, drawing partly on some of the emerging data from our research. That research isn't yet complete, so this is emerging thoughts, but also drawing on some of the experiences we've had as we've travelled around the country to different health and social care communities, many of whom are thinking about the future configuration of services and about the role of community hospitals in that future. Just in terms of joint working and the policy context, I guess joint working between health and social care, and indeed within the NHS as well, has long been a policy aspiration, at least as far back as the 1970s. At different stages we've made greater or lesser degrees of progress, but joining services up at the front line has still remained a challenge, partly because of the complexity and the time that is taken in building the right kind of relationships with different organisations and with colleagues from different professional backgrounds, but also because we're operating in a system that wasn't designed with integration in mind. When you think about that policy context, you could see community hospitals and the range of services and the range of professionals that they bring playing a key role in that integrated care agenda. And in rural areas in particular, you could see that estate, that co-location of services, as potentially being a crucial contribution to ongoing attempts to deliver integrated care. Having said all that, the policy context is currently very challenging, both financially and in terms of the breadth and depth of organisational changes that are taking place in many parts of the country, and maintaining some of our relationships with partners and creating the headspace to think about our role in a rapidly changing policy context is really difficult. Some of the feedback we had from the national evaluation was that the learning events we created for our case study sites were actually really helpful in terms of providing people with some protected time to really engage with and think about the issues at stake, to take a step back from the busyness of the day-to-day and to try and think about the debates and the changes that were taking place, and to articulate the contribution of community hospitals within those debates. Moving on to the evidence base, the evidence suggests to me that there's one thing that probably won't work and two or three things that might. Over time, we've learned both from bitter experience and from the formal evidence that large-scale organisational changes, mergers for example, tend not by themselves to deliver stated objectives. We often try and deliver integration by integrating organisations, but the evidence suggests that it can reduce morale and productivity, it can stall sometimes positive service development in the short term, and it can cause quite significant concerns for staff and for managers, not least because creating the new organisational entity, bringing the merger about, temporarily becomes an end in itself rather than just a means to an end of better services and more integrated care. That's not to say that changing services can't be part of a broader solution. It's just that wholesale changes probably aren't the best place to start in terms of full-scale organisational mergers. More promising, we think, are approaches which do a number of things. First of all, it's really important to be clear about the outcomes that we're trying to deliver by working together and by integrating care. That sounds a really basic statement, but all too often we find that partnerships aren't clear about what they're trying to deliver, and so everyone ends up slightly disappointed because no one way of organising or relating to each other could ever deliver so many often unarticulated and sometimes potentially incompatible outcomes. In public services, we also have a bit of a tendency to think about the world in terms of process and structure. So we often ask ourselves, well, what's the problem or what's the opportunity? What do we set up? How do we design it? Where would it sit? How does it report? All important questions to answer in the fullness of time, but probably not the most fundamental questions. And we try and get around that by saying, well, what outcomes are we trying to deliver together? And how well do current services do it now? And slightly naively, I'd argue, if we had a genuinely shared understanding of where we're trying to get to and a genuinely shared understanding of where we are now, the bit in between, what do we do, what do we set up, how do we work together, ought to be more straightforward. Or at the very least, we'd have some sort of success criteria against which we could judge the different options. So it may be worth community hospitals and all the professions and all the services that are involved asking themselves at local level that question: do we know what outcomes we're trying to deliver together, and would our partners answer that question in the same way as we would if we had that conversation? A second thing that can be really beneficial is to pay specific and careful attention to issues of professional values and culture. We all come from different professional backgrounds. I was a social worker by training, and the value base of our profession is often key to who we are and how we do things, and our professional status can often be a key part of our identity. When we come together into interprofessional settings, it's easy for people to feel threatened, as if their professional status and identity is being challenged, and they often take several steps back from each other metaphorically. They more jealously guard what makes me a social worker and the other person a nurse. And it's often only through a process of coming together and through working through these issues that we feel more confident, that we can take a couple of steps forward again, that we can meet the other person halfway and meet them as a real person rather than just as a professional stereotype. So just putting people together in a building or in a service doesn't tend to break down barriers or create more integrated care unless we're very careful about how we identify and work with professional values and culture. And then thirdly, there's something really important for me about trying to deliver outcomes that matter to service users and patients, and to be very person-centred in terms of the care that we deliver and the outcomes that we try and achieve. Actually, if we start with what matters to people, we could build up the relationships and the structures and the services that we need accordingly in a way that's bottom up, starting with the person, rather than trying to integrate care necessarily by doing it top down, by integrating services and structures and budgets and management teams. And actually, if we could integrate care bottom up in a person-centred way and integrate care top down and find a way of the two meeting in the middle, then we might really have some progress. So three other things that may be important to think about are, as I've said, the extent to which we're clear about the outcomes we're trying to deliver, the extent to which we're working meaningfully with values and culture in our health and social care professions, and the extent to which we're being truly person-centred and we're trying to organise care around the needs and the aspirations of the individual. So moving on to the implications of some of this for community hospitals, there are a number of thoughts that have struck me as I was preparing for today. The people listening will be experts in these issues, but I'd be interested in the extent to which those lessons from the policy context and the research evidence chime with your experience in local services. First of all, in terms of large-scale organisational changes, there's just a lot of them happening around the country, particularly in areas I suspect that may have very active community hospitals. And when that happens, there's often financial pressures, there's rapid organisational changes. It can be very difficult to think through what's the role that we play, where do we fit, how do we organise so that we can be as effective as possible. So it does feel a very, very difficult and challenging context for community hospitals to be operating within. The key thing for me is that we try and be proactive about that. We try and get on the front foot. We're clear about what we have to offer. We're clear about how and where we could fit. And we're clear about why we're a key part of the solution. Doing that probably involves a key relationship with and an understanding of our local community. And although we often say that that's a key hallmark of community hospitals, I suspect it may vary in practice around the country about the extent to which we're simply a hospital that's based in a local community, if you like, or are we a hospital that really understands the needs of and engages with in a two-way process the nature of our local community. The more we can do the latter rather than the former, the easier it might be to contribute to some of these debates. In terms of being clear about outcomes, many of the community hospitals that I've visited have sometimes been quite large organisations, sometimes been quite small organisations, but they've often been a hub for a range of different services and a range of different professionals. And a question that arises for me is where the leadership and also the space comes from for us to bring that richness and complexity together, to have those conversations about the extent to which we agree around shared outcomes. It may be that sometimes we're a series of different services working out of the same building, rather than necessarily a set of partners that are working together towards shared outcomes. Again, I suspect that will vary quite dramatically around the country and from hospital to hospital, and you may want to think about how you'd locate your own hospital and your own services on that spectrum. Similarly, when it comes to working together on culture and values, again, do we have the processes and the space to come together to do some of that work, or are we different providers, different professions, using the same buildings but working in different ways? And then finally, just a link to the importance of being person-centred. Our research is suggesting that lots of patients feel really welcomed and really valued in the community hospitals that we've visited. Not always, but often the patient experience has been very positive, and people have been very positive about it, both in its own right and when comparing it to their experience of some inpatient stays in acute care. That seems to me to be crucial, but it does also raise some further questions. In some areas, part of that patient experience seems to be linked into having a very local service with staff who are also from the same community, where there's a degree of continuity, where you may know more about the person and their context before they come in, and where there's a strong identity between the local community and the hospital. In other areas of the country, there may be quite widespread changes taking place, where hospitals are becoming bigger, where they may be covering bigger catchment areas as a step-down service from acute care. And there's probably an ongoing question about how we try and retain some of those traditional approaches and traditional values in a new policy context. One final issue around person-centredness that we've been reflecting on as well, although many services seem to do this very well, on the whole, we have seen a number of examples where the older person in particular, where it's an older person, has been going through quite profound life changes. And yet, because we approach some of these issues from a service perspective sometimes, we haven't fully appreciated the extent of those life changes. So you may hear a member of staff saying, actually the person's been in here for quite a long time, they can't stay forever, they need to move on somewhere else. When actually we're talking about somebody who may not be able to go back to the home where they've lived with their partner for the last 60 years and is making a fundamental choice about their future that speaks not just to the practicality of their situation, but to the psychology of the decision that they have to make. Have we fully appreciated the human, the psychological, the emotional aspect of that transition? Or do we sometimes see it as being a service transition from one service to another? As I say, from our data so far, people have very positive patient experience on the whole. They feel welcomed, they feel staff are very caring and very hardworking and very warm, and are very holistic in terms of how they work. But a challenge from us back to some of our case study sites has been the extent to which we're fully sighted on and working with the emotions of the transition that the person may be going through. There'll be further details from the study to come out in due course. There's a project website and there's some other studies coming out as well that are part of the same programme. The Community Hospital Associations has been a key source of expertise, a key partner, and is doing a great role in terms of coordinating that activity and making sure that we learn the lessons across the board. So there'll be some further detail about the national evaluation in due course. This was a little bit of a precursor to share some of my thinking as we start to analyse our data, as we start to reflect upon the current policy context. So lots of changes taking place. Difficult sometimes to be clear about the outcomes we're trying to deliver, or to find the time and the space to work on values and culture, and difficult trying to both manage efficiency and effectiveness and service transition whilst also trying to think about the human nature of that transition and the emotions that the person may be experiencing. At the same time, community hospitals have got a key role to play, I'm sure, in many of those debates. And if community hospitals don't have the answer, then in one sense, who does? So for me, it's a challenging policy context, but it's also an opportunity to think through what role do we play, what are we good at, what do we value, how do we mainstream that, how can we be proactive and on the front foot. I hope you enjoy the rest of the conference, and I hope this video clip's been helpful.